this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP and for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
And we're going to get started with Marissa Grillo. She's a PGY2 emergency medicine resident at Hackensack University Medical Center. And today she's going to be presenting on dual antiplatelet therapy versus Alteplase for patients with minor non-disabling acute ischemic stroke, the ARAMIS randomized controlled trial.
Sure. Thank you for that introduction. Again, my name is Marissa Grillo. I'm the PGY2 Emergency Medicine Pharmacy Resident at Hackensack University Medical Center. And the journal club that I've chosen for this week is dual antiplatelet therapy versus Alteplase for patients with minor non-disabling acute ischemic stroke, otherwise known as the ARAMIS randomized clinical trial. So some objectives for today's meeting is to outline the etiology and management of acute ischemic stroke, to identify previous literature and guidelines pertaining to the management of acute ischemic stroke, and to evaluate the use of dual antiplatelet therapy versus intravenous thrombolytic therapy for minor non-disabling acute ischemic stroke as presented in the ARAMIS clinical trial. So just as an overview of stroke in general, it can be broken down into two broad categories. We have hemorrhagic stroke and ischemic stroke. And ischemic stroke can further be broken down into 5 subtypes according to the TOS classification criteria published in 1993. And that includes small vessel occlusion, cardioembolic ischemic strokes, large vessel atherosclerosis, other determined etiology, and undetermined etiology, which can present as 2 or more causes identified, negative evaluation of the patient, or incomplete evaluation of the patient. And ischemic strokes make up 87% of all strokes presented, with up to 50% of them being non-disabling, which I'll touch on further when I go over the trial. As for some risk factors for acute ischemic stroke, we have modifiable and non-modifiable risk factors. Our modifiable risk factors include alcohol use, atrial fibrillation, diabetes, hypertension, hyperlipidemia, physical inactivity, obesity, and smoking and tobacco use, all of which can be modified with introducing lifestyle modifications into our life, as well as medications. And non-modifiable risk factors such as age over 55 years old, gender, so females are more likely to be predisposed to having acute ischemic stroke, any family history of stroke, previous stroke history, and race. And it's been found that African American patients, Asians or Pacific Islander patients, and Hispanic patients are more likely to experience acute ischemic stroke. The 2 of the scales that I'll be touching on when I introduce previous literature and the trial today are the NIHSS, or the National Institute of Health Stroke Scale, and the ABCD scale for transient ischemic attacks. The NIHSS, the National Institute of Health Stroke Scale, is an 11-point scale that touches on the symptoms of when patients present with stroke, touching on level of consciousness, how they move their eyes, their visual fields, any facial drooping, any deficits in arm or leg movements, limitaxia, sensation, the language, and extinction and inattention. And the ABCD scale looks at age over 60 years, blood pressure over 140 to 90 millimeters mercury, any clinical features of weakness or speech disturbance, duration of symptoms, and history of diabetes. And it's important to note that for these 2 scales, the higher the score, the more severe the stroke or the transient ischemic attack. So you'll see on the NIHSS score that scores of 0 and 1 to 4 consist of either no stroke symptoms or minor stroke, with 5 being moderate stroke and above moderate to severe and severe stroke. Now, the literature varies in which they consider for minor stroke. So an NIHS score of 0 to 5 is going to be what we're considering a minor non-disabling acute ischemic stroke as presented in the trial that I'll discuss and the current guidelines. As for the ABCD scale, the higher you go, the more at risk you are for a 2-day risk for stroke and risk for recurrence at 90 days. So for current guideline recommendations, I'm going to be going over the 2018 American Heart Association and American Stroke Association guidelines for the early management of patients with acute ischemic stroke, as well as the 2019 update. So as 2018, there was a level 2B recommendation for otherwise eligible patients with mild stroke presenting in the 3 to 4.5 hour window. Treatment with intravenous Alteplase may be reasonable, and those treatment risks should be weighed against possible benefits when the provider is determining whether to administer this medication. The AHA and ASA came up with the 2019 update that said it was a level 1 recommendation for otherwise eligible patients with mild but disabling stroke symptoms. Intravenous Alteplase is recommended for patients who can be treated within 3 hours of ischemic stroke symptom onset or patient last known well or at baseline state. They also introduced a level 3 recommendation where you see no benefit. So for otherwise eligible patients with mild non-disabling stroke symptoms and that NIHSS score of 0 to 5 that I touched on previously, intravenous Alteplase is not recommended for patients who can be treated within 3 hours of ischemic stroke symptom onset or patient last known well or at baseline state. Now, there are new criteria that tenecteplase has been seen to be non-inferior to Alteplase in the management of acute ischemic stroke. However, as per the guidelines in the trial that I'll be discussing, I'll just touch upon Alteplase as our fibrinolytic therapy. So as for our medication management, we have Alteplase, which is our FDA-approved treatment for treating acute ischemic stroke. It induces fibrinolysis by binding to a fibrin in the clot, converting plasminogen to plasmin, therefore breaking up the clot. And it's dosed at 0.9 milligrams per kilogram to a maximum of 90 milligrams. Administered as a 10% bolus and a 90% slow infusion. On the other side, we have dual antiplatelet therapy, or DAPT, which I'll be referring to in this presentation. And that is a combination of 2 antiplatelet agents, aspirin and a P2Y12 inhibitor, such as clopidogrel, prasugrel, or ticagrelor. And this works by inhibiting the COX-1 and 2 enzymes and P2Y12 receptors on the platelet surface, decreasing platelet aggregation. And depending on which formulation of aspirin you use or which P2Y12 inhibitor you use, you'll see variable dosing for this medication management strategy. So to touch on some of the previous literature, I'm going to be going over a couple of trials that have looked at dual antiplatelet therapy or single antiplatelet therapy alone, and then we'll move on to our IV fibrinolytic therapy versus our antiplatelets. So the first trial that I have is called the CHANCE randomized controlled trial, so clopidogrel with aspirin in acute minor stroke or transient ischemic attack, published in the New England Journal of Medicine in 2018. The objective of this trial was to assess if combination therapy with clopidogrel and aspirin may provide greater protection against subsequent stroke than aspirin alone. This was a randomized, double-blind, placebo-controlled, multi-center trial that looked at patients with acute minor stroke, defined as a score of 3 or less on the NIHSS, or a transient ischemic attack defined as a score of greater than or equal to 4 on the ABCD scale. Patients were randomized to receive clopidogrel 300 milligrams on day 1, followed by 75 milligrams per day for 90 days, along with aspirin, 75 milligrams per day for the first 21 days, or placebo and aspirin, 75 milligrams per day for 90 days. The primary outcome was stroke, either ischemic or hemorrhagic, during 90 days of follow-up in an intention to treat analysis. Stroke occurred in 8.2% of patients in the clopidogrel plus aspirin group versus 11.7% of those in the placebo plus aspirin group, shown to be statistically significant. And moderate or severe hemorrhage occurred in 0.3% of patients in the clopidogrel and aspirin group versus 0.3% of patients in the placebo and aspirin group, not statistically significant. So the authors concluded that among patients with transient ischemic attack or minor stroke can be treated within 24 hours after the onset of symptoms, the combination of clopidogrel and aspirin is superior to aspirin alone for reducing the risk of stroke in the first 90 days. The second trial that I will be touching upon is the POINT randomized control trial, looking at clopidogrel and aspirin in acute ischemic stroke and high-risk transient ischemic attack. This is also published in the New England Journal of Medicine in 2018. The objective of this trial was to assess if combination antiplatelet therapy with clopidogrel and aspirin may reduce the rate of recurrent stroke during the first 3 months after a minor ischemic stroke or transient ischemic attack in an international population, similar to the CHANCE trial. This is a randomized, double-blind, international, placebo-controlled trial with patients presenting within 12 hours after having an acute ischemic stroke with a score of less than or equal to 3 on the NIHSS, or high-risk DIA with a score of greater than or equal to 4 on the ABCD scale. Patients were randomized to receive clopidogrel with a load of 600 milligrams on day 1, followed by 75 milligrams per day, plus aspirin for 90 days, or aspirin alone for 90 days. The risk of a composite or major ischemic event, which is defined as ischemic stroke, myocardial infarction, or death from an ischemic vascular event at 90 days, was the primary outcome. Major ischemic events were seen in 5% of patients receiving clopidogrel and aspirin, and in 6.5% of patients receiving aspirin plus placebo, shown to be statistically significant. They also saw that major hemorrhage occurred in 0.9% of patients receiving that dual antiplatelet therapy and 0.4% receiving aspirin plus placebo. So the authors concluded that in patients with minor ischemic stroke or high-risk DIA, those who received a combination of clopidogrel and aspirin had a lower risk of major ischemic events at a higher risk of major hemorrhage at 90 days than those who received aspirin alone. And the last trial that I'll touch upon is the PRISMS randomized control trial, looking at the effects of Alteplase, or a fibrinolytic, versus aspirin on functional outcome for patients with acute ischemic stroke and minor non-disabling neurological deficits, published in JAMA in 2018. Now, the objective of this study was to evaluate the efficacy and safety of Alteplase in patients with an NIHSS score of 0 to 5, whose deficits were considered non-disabling. This was a phase 3 double-blind, double-placebo, multi-center randomized clinical trial looking at patients with acute ischemic stroke. The patients were randomized to 0.9 milligrams per kilogram of intravenous Alteplase plus oral placebo, or 325 milligrams of oral aspirin plus intravenous placebo. The primary outcome was the difference in favorable functional outcome, defined as a modified Rankin scale score of 0 or 1, 0 being no symptoms present, and 1 being symptoms present, but the patient would not be clinically disabled, at 90 days, stratified by the pretreatment NIHSS score, age, and time from onset to treatment. They saw at 90 days, 78.2% of the patients in the Alteplase group versus 81.5% in the aspirin group achieved a favorable outcome, and 3.2% of Alteplase treated patients versus 0% of the aspirin treated patients had spontaneous intracerebral hemorrhage. So the PRISMS randomized control trial investigators concluded that among patients with minor non-disabling acute ischemic stroke, treatment with Alteplase versus aspirin did not increase the likelihood of favorable functional outcome at 90 days. And now we're going to move into the trial that I've chosen to discuss today, Antiplatelet versus RTPA for acute mild ischemic stroke, otherwise known as the ARAMIS randomized clinical trial. This is a multi-center, open-label, blinded endpoint, non-inferiority, randomized clinical trial, and the objective was to investigate whether DAPT is non-inferior to IV thrombolysis in patients with minor non-disabling acute ischemic stroke. This is done across 38 hospitals in China from October 2018 through April of 2022. Patients were included if they were greater than or equal to 18 years old, if they had a confirmed acute ischemic stroke on CT or MRI at admission, if their NIHSS score was less than or equal to 5, with less than or equal to 1 point on single item scores, and 0 in the consciousness item at the time of randomization, and if they were able to receive study treatment within 4.5 hours of stroke symptom onset. Patients were excluded if their pre-stroke disability consisted of a modified Rankin scale of greater than or equal to 2, 2 being symptoms present with disability, a history of intracerebral hemorrhage, or definite indication for anticoagulation. Patients were randomized in a 1-to-1 ratio to either DAPT, for which they received clopidogrel 300 plus aspirin 100 milligrams on day 1, and on days 2 to up to 14, they received clopidogrel 75 milligrams plus aspirin 100 milligrams, and following that, single antiplatelet therapy or guideline-based dual antiplatelet therapy up to 90 days. In the other treatment arm, patients were randomized to Alteplase, where at presentation they received that 0.9 milligrams per kilogram, done as a 10% bolus and a 90% infusion over 1 hour. And 24 hours after thrombolysis, they received guideline-based antiplatelet treatment until 90 days. As for the primary outcome of this trial, it was excellent functional outcomes, so that modified Rankin scale score of 0 or 1. Secondary outcomes consisted of favorable functional outcomes, so an MRS score of 0 to 2 at 90 days, early neurological improvement at 24 hours, defined as a greater than or equal to 2-point decrease in the NIHSS score, new stroke or vascular event at 90 days, and 90-day all-cause mortality. Safety outcomes consisted of symptomatic intracerebral hemorrhage up to 90 days or any bleeding event during the study time period. As for statistical analysis, this trial used a one-sided alpha of 0.025. They estimated a sample size of 666 patients were needed to achieve 80% power, and they chose a non-inferiority margin of 4.5%. And this is based on the third international stroke trial with a finding of 9% difference in proportion of favorable outcomes in a subgroup analysis of patients with minor stroke treated with intravenous Alteplase versus standard medical treatment. 835 adults were assessed for enrollment, with 775 being eligible and 760 randomized to dual antiplatelet therapy or intravenous Alteplase. 393 patients were in the DAPT group versus 367 patients in the Alteplase group. For baseline characteristics, they were pretty similar between each group. So ages, 65 was the median age in the dual antiplatelet therapy group versus 64 in the Alteplase group. About 30 to 31% of patients in each group were female. And the time from onset of symptoms to receipt of assigned treatment was similar between the two groups as well, ranging from 180 to 182 minutes. Then NIHSS score at randomization was between 1 and 3 for both groups. And the estimated pre-stroke function, or the MRS score of 0 to 1, was also similar between the two groups, with the majority of patients in each group having an MRS score of 0. For the primary outcome of excellent functional outcome within 90 days, 93.8% of patients in the dual antiplatelet therapy group versus 91.4% in the Alteplase group achieved this outcome. You see in the unadjusted analysis that the treatment difference was 2.3%, which was statistically significant based on that lower boundary of the 95% confidence interval being greater than the negative 4.5% non-inferiority margin chosen. And you see the same in the adjusted group, and this outcome was adjusted for pre-specified variables of age, sex, history of diabetes, NIHSS score at randomization, the time from symptom onset to the receipt of the assigned treatment, location of the responsible vessel, and stroke etiology, still being statistically significant. For the secondary outcomes, the only statistically significant outcome was the early neurological deterioration within 24 hours. 4.6% of patients were seen to have this in the DAPT group versus 9.1% of patients in the Alteplase group. For the unadjusted and adjusted variables, they were both statistically significant. And as for the safety outcomes, incidence of symptomatic intracerebral hemorrhage was not statistically significant. 0.3% of patients in the DAPT group saw this versus 0.9% in the Alteplase group. However, any bleeding events was statistically significant, so 1.6% of the patients in the DAPT group versus 5.4% of patients in the Alteplase group. So the authors concluded that among patients with minor non-disabling acute ischemic stroke presenting within 4.5 hours of symptom onset, that dual antiplatelet therapy was non-inferior to intravenous Alteplase with regard to excellent functional outcome at 90 days. Now, to critique this study, I'll first look at the population. So some of the strengths of this study included that there was no significant imbalances in baseline characteristics between the groups. There was a large sample size, and this consisted of multi-center recruitment. However, the study was only done in China, so there was a lack of diversity and therefore a lack of generalizability to other nations. Patients with a stroke caused by cardioembolism were excluded. So of those 5 classifications of acute ischemic stroke, we cannot apply this study's findings to patients who have suffered from stroke by cardioembolic causes. And a much lower percentage of women were enrolled than men, so only 30% in each group were women. As for the methods, some strengths were that this is a 1-to-1 randomization and the trial was a non-inferiority design. However, this trial was not placebo-controlled and there was seen to be a high crossover rate between the groups. Now, this high crossover rate was attributed to consent misunderstanding and fluctuations in the neurological deficits of the patients, where the providers requested that they be put in a different treatment arm. The study also enrolled patients in between that 2019 update to the American Heart Association and American Stroke Association acute ischemic stroke guidelines that stated the different levels of recommendation for intravenous Alteplase in patients with non-disabling acute ischemic stroke. As for interventions, there were evidence-based interventions in each arm recommended by the guidelines, and there was appropriate dosing based on previous trials that I had mentioned, package inserts, and guidelines. However, this trial did use an aspirin 100 milligram formulation, so it might not be as generalizable to places that don't carry aspirin in 100 milligram formulations, such as the US. We have aspirin 81 milligrams and aspirin 325 milligrams, so we'd have to decide which one of those to use because we don't have 100 milligrams available to us here. As for endpoints, the trained assessors of the outcomes were unaware of the treatment group assignment. Secondary outcomes were assessed up to 90 days, which is standard for stroke trials. And I'd like to commend this study on looking at patient-centered outcomes. So we look at treatment and we mostly sometimes are clouded by the fact that they can either cure the disease state or not cure the disease state, and we lose sight of if the patient will live a valuable quality of life afterwards. So I'd like that this trial looked at patient-centered outcomes as the modified ranking score for excellent functional outcomes. However, the study team members were unblinded to treatment randomization, and the neurologist determining neurological improvement was unblinded to the treatment assessment, which could lead to bias. Statistics, appropriate alpha and beta values were used. Enrollment was meant to achieve 80% power, and that choice of non-inferiority margin of 4.5% was backed up by previous literature. However, high rates of the primary outcome in each group could lead to a ceiling effect. So we saw that over 90% of patients in each group, the dual antiplatelet and the Alteplase group, achieved excellent functional outcome. So because both of the managements work so well, we couldn't tell if one is better than the other. However, this was designed as a non-inferiority trial. So we were only measuring to see if dual antiplatelet therapy was not worse than IV fibrinolytic therapy. So as for my conclusions of the ARAMIS clinical trial, in the select subgroup of patients with minor non-disabling, non-cardioembolic acute ischemic stroke presenting within 4.5 hours of symptom onset, dual antiplatelet therapy can be considered over intravenous Alteplase based on patient safety, efficacy of the intervention, and cost. and I could take any questions at this time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.